One of, I think, the most effective communication strategies is to remember that we're sort of all on the same team. And people are, if you assume that people have the best intentions, then I think that helps you reframe ineffective communication into, okay, maybe this is a stressful situation and this individual doesn't know or isn't equipped to deal with the stress. It's not that they're calling me with a crappy handoff because they don't like me because it's 2 a.m. and I'm an intern and they're just trying to give me a hard time. No, it may very well be because this person has the best intentions. They want to help this patient, but for a number of factors that maybe you don't have visibility on, they're just not doing it very effectively. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm Dr. Cyrus Askin.
And I'm Dr. Nick Mark. As fans of the show know, this season we've really tried to lean into our big tent focus. And in addition to our just perennial constant focus on hardcore physiology that we all love to nerd out about, we've decided to talk about some other topics this season. Things like dying with dignity, 3 wishes, palliative care in the ICU. And we've also tried to explore the experience of being an ICU patient from the patient's perspective.
That's right. Well, we have every intention of continuing to nerd out, of course. We do maintain that it's important to cover some of the more nuanced elements of what we do in our line of work. Perhaps nothing is more nuanced than how we communicate when we're trying to care for the critically ill.
That's right. And if you've ever been to an M&M or you've ever been to a risk management meeting or you've reviewed some patient safety event, you know how important clear, concise, effective communication is. And so in this episode, we're going to focus on another element that's really critical in communication in the ICU, which is communication between clinicians and bedside nurses.
To help us unpack this, we're joined by Genae Christensen. Genae is an MS2 at the University of Utah School of Medicine. Prior to starting medical school, Genae spent 13 years as a critical care nurse. This time includes some work that she did in the CT ICU, in the MICU, and in a COVID ICU as a bedside nurse. She's got experience at a level 1 trauma center, experience as a VAD coordinator, as an ECMO program lead, and as a CT ICU department manager. So you'd think that's enough, but no. She's also spent some time on Rotary Wing working with her local life flight program. And she, in fact, continues to work as a flight nurse in that regard. And all of this is done while balancing the responsibilities she has as a medical student. So, Nick, I just don't think we could do any better than this. We've got a phenomenal guest who's going to help us delve into communication in the context of critical illness.
I'm so excited. And by the way, just going to throw one more plug about how great she is. She's also a fan of the show. That's how we got to know her. She reached out. And so if you too are a fan of the show and you have a story, you too should reach out because maybe we'll have a really good opportunity to meet and talk about it.
That's right, Nick. Hopefully you guys out there will hear us talking and get inspired. We'd love to engage with our listeners, with our fans. And so, again, we're super excited about this. I don't want to delay us anymore, so let's just jump into the episode.
Genae, welcome to Critical Care Time. Thanks so much for being a fan. Thanks so much for joining us today. We really appreciate you being here.
Thank you both for having me. I love your show. It was actually shared with me from a friend sometime back in the winter time or maybe what is Utah spring. And I have listened to all the episodes. And I think it was actually the episode after your Code Blue dialogue and how you kind of dissect a Code Blue scenario that kind of stood out to me and reached out. So thank you.
Thank you. Well, so, I always like to ask people when they're guests on our show what their superhero origin story is. You've had a really interesting path in medicine. Maybe you can tell us kind of what got you to the present. How did you do all these things and what's sort of the thread that connects them?
Yeah. So thank you for the opportunity. I started in healthcare, really exploring the option when I was an undergrad. So I went to the University of Utah as an undergrad. And at the time, I really was debating between healthcare and engineering, actually. And I really just love the process orientation of physiology and how things interact with each other. And I felt at the time really just thankful to be in college. And I was in college under a scholarship. And so no one in my family or friends at the time had any association with medicine beyond my mom, who was a nurse. And it was really abstract. So I didn't know the path to really pursue becoming a physician. Of course, there's the financial obstacle. There's, the, folklore of a very demanding lifestyle. And so that may not be conducive to long-term plans or family plans. And so at the time, I really pursued nursing because that seemed to fit my financial capacity, my ability and interest within healthcare. And I did my capstone in a surgical cardiac ICU where I actually started as a new grad. From there on, I really found I loved the ICU. And really, when you love things, you start filling your time with them. And so I found just expanded roles kind of present themselves once I was in the ICU. And I joined our specialty life flight transport program where we would transport ECMO patients or patients on Impella or VADS as a specialty team member. And then I got the opportunity to be a VAD coordinator for a couple of years. And I really actually loved that because that really highlighted to me the relationships that you can make with patients as over time and through a really robust relationship with the healthcare team. And it seemed like everywhere along the way, there was just another opportunity that presented itself. And I loved what I learned as a manager of the department and got to learn a little bit more of the business side and really found that I loved the clinical side. I know that the business side is certainly a necessity at times, but I also really love and gravitate to the clinical side. And when a position opened up within the Life Flight program, which is your rotor fixed wing transport in Utah Intermountain area, I really, really loved the autonomy and the decision making and the application that really went into high critical care, high stress, high emergency environments.
Yeah, I was going to ask because it's kind of interesting going from, what seemed to be that administrative route of medical leadership, program direction, all that, and then you pivoted pretty hard back into the clinical world. So can you unpack that a little bit more for me? Help me understand what it really was that triggered that move?
I really loved Life Flight from my exposure and opportunity within that environment of the specialty transport within ECMO, VAD, Impella, all of that. And I had spent a good chunk of time trying to, of course, do my best within an administrative role. And I got my MBA and I tried very hard to understand the business side. And I'm thankful for that because it taught me so much about people and it taught me a little bit of maybe thinking outside the box of some of the why behind healthcare, admin decisions get made. But at the end of the day, I really love people and I really loved the clinical, direct care of patients. And I felt like it was a closer match to being in a position that was more providing that care than maybe an administrative type position.
And so I'm curious. So you really were kind of like this absolute expert taking care of like the sickest patients in the state, doing interfacility transports of people on all kinds of devices, all kinds of support with a fairly large amount of autonomy. I'm curious what it was that made you say, nah, I want to just like crack open books and go back to med school. Like, what was that transition like?
That actually was COVID. So COVID definitely had its own phases of critical care. And I would say, man, that would be something whole different to unpack, all of the different kind of waves of experience within COVID, not just waves of COVID itself.
We owe our listeners an episode, at least one episode on that. You're absolutely right.
Yeah. But for my experience, I had kind of a hybrid COVID experience where I was both in this interfacility transport environment, a lot of patients who with really sick ARDS from COVID would wind up in hospitals that had to triage, can we care for them here or do we need to send them to a tertiary care center? And so we found a lot of exposure from a transport environment in both the stabilization and really dynamic phases of that. And then I also found myself in this kind of moral obligation point where I actually felt this degree of guilt having been an almost decade prepared ICU nurse at that point and having just left, the ICU environment to this transport environment. And in some of the phases of COVID, there was a lot of the canceling of elective or semi-elective type areas and redeploying staff to try and expand COVID, extreme COVID care or COVID capacity. So Intermountain had both expanded beds as well as found different areas in space to be able to care for ICU patients. And I really found myself with this desire to both be in the ICU, supporting both patients and my fellow nursing workforce. I found that sometimes these nurses who had never set foot in an ICU environment maybe had exposure in a clinic setting, and now they were being asked to monitor very critically ill patients, report on findings, figure out how to navigate a really high-stress environment that was probably injuring them to a moral degree, right? So I found myself with this split desire to both care for patients in the ICU as well as really dive into and embrace my role in Lifelight. So over time, I found as I watched a lot of my peers really go through very real periods of burnout, and a lot of them left the ICU. A lot of them left nursing altogether. A lot of physicians retired. A lot of people just left the field. And I found my commitment to healthcare actually really questioned and actually deepened. So as I kind of went through these reflective phases of COVID and recognizing that my commitment to medicine and to people were deepening, I really kind of took a step back and thought to myself I should seriously consider what that role within medicine would look like.
Man, that's awesome. I think a lot of that story resonates with, I think, both Nick and myself in regards to the, quote unquote, working in the trenches. I hate that expression. It sounds so melodramatic, but I mean, it's somewhat,
does that go over well in the Army, dude?
Yeah, I know it's good question, right? I mean, I can assure you that it's used not infrequently in our line of work, Army or not. But your story kind of brings back some memories because I was a fellow at that time and would kind of oscillate between loving what I was doing and feeling very gratified, and then just feeling completely beaten down in every possible conceivable way. And I'm sure, Nick, it was similar for you, your experience. But I do want to ask, and eventually we're going to get to the meat and potatoes here, but I just think your story is a really interesting one. And in particular, the question that I'm going to ask, which I'm sure you get all the time, is, so you ultimately took all of that motivation and ended up going to medical school, and there you are, currently as an MS2. Wouldn't it have been so much easier to just go into NP school? I mean, isn't that the path of least resistance for someone who has all of this bedside nursing experience?
I definitely think it's the expected one.
Sure.
Definitely get asked that question, and I really kind of had to reflect on that myself as I was preparing for med school applications. I actually did start an application to NP school. It was probably in about 2015. Around that time, I had started to take on expanded roles, and I was a VAD coordinator, and I had a lot of really mentors in the ICU, both nurses and physicians, who were so good about teaching me and recognizing how much I loved to learn. And there was a lot of encouragement to pursue some sort of advanced degree. And I think at the time, I found myself not really having a good why. I felt like it was what I was supposed to do. I couldn't really answer the question, why was I applying to be a practitioner? Was I applying to just do it because that's what the next step was supposed to be? And I guess, fast forward 5 years, it was November of 2020 because it was Thanksgiving time. And I was actually driving from Utah to Oklahoma to visit my sister. And at the time, air travel was even still on this type of moratorium. And I started to kind of reflect on what my why was. And I started to kind of put together some of these, I guess, thoughts I had to deal with some of these, seeing face on some of the very real difficulties that COVID brought. So I think I was reflecting on my values and trying to decide exactly what I wanted an advanced practice role to look like and why I wanted to be in that. And it really came down to what the team looks like within I love the critical care setting. And so what does that team look like? And while everyone on the team contributes to an overall culture, absolutely, I really feel like a lot of the tone is set by the attending, by the leaders. They either foster education, they foster growth, they foster development, or they can have the opposite effect and they can have more of a detriment to a culture of an environment. And I think because I was so engulfed in what my commitment to medicine really was, I really wanted to be true to myself and what I wanted to embody. And I really wanted to be a part of setting the culture that I felt like was the direction forward.
I think that's a really great point. And I think, this is slightly cheesy to reference this after your heartfelt story there, but one of my favorite things about the TV show ER is that the sort of in the first episode of the show and then periodically thereafter, they have this, this sort of like you set the tone is sort of like what one character speaks to another. And I think that's really true. Like that's really very much what like a leadership role in the ICU is, and whether that's like the tone, uh, on rounds, the tone of the day, the tone in dealing with a crisis. Like, I think that is a really important role. And I think it's also a great segue to the other thing that we want to talk about today, which is communication, right? Because like setting the tone really is sort of it's sort of like the total of verbal and nonverbal communication and mentoring and all these little things sort of together define the quote unquote tone. So, I mean, I guess to bring this to a question. So now that you're in the midst of med school, can you comment on how communication skills are taught differently as a nurse versus as a physician?
Yeah. So this has actually been fun for me to learn, and it's a big challenge because in the nursing side of my education, I was really focused on my communication being one that is advocating, escalating a concern, focused on how to articulate something that needed to be addressed. And I do think that that is such an important and valuable part because sometimes, where the nurse is caring for the patient longitudinally with, hour after hour, you pick up on subtleties that are missed by just laying spot checks on something. But, the articulation of that concern sometimes can be difficult to really get the magnitude behind or grasp what the actual problem is in a tangible fashion, especially if it's this trend, this subtle trend, Within the medical education so far, the thing that I know you guys know very well and I have come to learn is there's a very specific script. And that script is really designed to help train, I think, my brain to think about all of the complexities that go into synthesizing information and relaying that so that the ears listening are also on the same page about how to pick up on what the important aspects are. So following that kind of script in discussing a patient is probably the biggest difference between the two fields that I've learned so far.
Interesting. And I'm curious, there's sort of like these two sort of scripts sort of fit together sometimes. I guess we're going to talk about, later on we could talk about some like CRM concepts and kind of like structured ways to like escalate concerns and how to be like receptive to concerns and how to use certain words to trigger it. But I mean, it's interesting. It's interesting, this concept of like two different scripts and where the two scripts sort of come together. I guess there's no question there. That was just a rambling series of thoughts.
I think that hybrid of both how, a nurse interacts with the patient and how a physician interacts with the patient, as well as the communication styles present, is probably some of the underpinnings of where some communication goes wrong. It's just the approach to how the patient is being looked at and cared for.
Okay, I like that. I think we'll probably dive into some of that a little bit more as we continue our discussion. But it's a provocative idea. Another thing I wanted to make sure I got this out as I was looking through again your profile, your history. I thought this would be kind of an interesting question to ask you in particular. So, many parallels are drawn between flight and medicine. That comes up a lot on our podcast. Nick tends to bring that up, and I think it's often very appropriate. Sometimes not appropriate at all, and he's just like out to lunch. But most of the time, it's appropriate. I think one of the big things is decisions often need to be made decisively and swiftly.
Yeah.
And then beyond that, the implications of those decisions are not insignificant, right? I mean, we're taking care of often some very sick folks, and decisions need to be made appropriately and in a timely manner, et cetera, et cetera. And so, what I find interesting, I say what you will about Malcolm Gladwell. I've read some very interesting perspectives on his writing, but I read Outliers. I thought it was a pretty good book, and in that book, in one of the chapters, he discusses communication in the context of power dynamics, and specifically this idea of cockpit culture as it related to Korean air flights in the 80s and 90s, and how they had a tendency to crash, more so than other airlines at the time. And so I read that, and I read his explanation, and I immediately was thinking about the relationship between how nurses and physicians communicate, and how trainees and attending physicians communicate, to that end as well. And so, as someone whose experience spans that whole spectrum of someone who's been on rotary wing providing medical care, I'm just curious, like, if you can comment on the interplay between authority and hierarchy, and really the importance of direct and clear communication in that kind of a setting.
Absolutely. And I think that is a really good thing to dive into a little bit, because I think there are so many parallels between aviation structure of, authority and decision making, as well as medicine. We actually talk about this in flight all the time, because it is a hybrid of those two areas already, just inherently. And there definitely has to be some kind of basic assumptions. And these same basic assumptions, I think, are found in lots of places, right? But the basic assumption is that, good intent is first, the patient is first, safety is first, right? So if everyone is reminded that we are all operating from the best interest for the patients and ourselves, that actually is the right place to be operating from. So respond accordingly is, I guess, the overall tone there. I really actually loved Outliers. I read that also. And along those lines, I actually read another book called In Shock. And that is,
It's a great book.
it's a great book. Sounds like you're aware of it. And it was about an
Nick
intensivist.
is, I don't read. I don't actually know how to read. So
It's an
There's a pic-
intensivist who shares her own story of being critically ill. And which is, a really insightful perspective when you know how to operate and navigate from the work side of it, and you experience it yourself. So I guess, to pull back to the comments of authority gradients, to operate from a stance of clear, direct communication is really intended to be able to take care of life threats first, right? Is there an immediate safety threat? Is there an immediate life threat that needs to be addressed first and foremost? And so you have this kind of tier of decision making, and the way your communication should reflect what tier you're at. And then if you have something that needs to be dialogued, discussed, you ask for additional insight. And in that phase, you might be getting very granular, because you want to get additional thoughts on the table. It's your problem solving mode. It's your, think outside the box perspective. And so that aspect is where, an authority gradient needs to be recognized for decision making and decision rights, but that the seeking of information becomes all, right? Or mutual level, maybe.
I think those are great points, and I think that, yeah, like you both said. I mean, I think there's fascinating parallels between aviation and medicine. There's a lot of interesting things, like the way that we time out before a procedure and the way you brief before takeoff or landing. It's interesting too that aviation sometimes borrows from medicine. In the cockpit, they'll sometimes refer to the sterile cockpit rule, right? Like no extraneous conversations below 10,000 feet, which is obviously a nod to the operating room, where hopefully there are also times in a procedure when no extraneous conversations or no music is happening, but people are completely focused. I think it's really interesting that you've gotten to experience kind of both the aviation aspect of this and the medicine aspect of this. You mentioned some sort of like tools like that people can use to sort of present information, like SBAR, or like ways of like escalating concerns with words. Like, do you use cuss? Is that something you've?
I'm not as familiar with cuss,
Okay,
but,
we can edit that out.
there's certainly like voice a concern, escalate a concern, that same type of mindset, that framework.
Yeah, so where I trained, we were very big on this like CUS framework, which was like this sort of three-level escalation, which was like I'm concerned about, I'm uncomfortable with, this is a safety issue, which was like that. And so we'd say like, oh, a nurse just cussed at me or whatever. But I mean, it's actually a very effective thing. And the funny thing
Yeah.
is that like once you exist in this framework for long enough, it doesn't feel forced at all, right? Like I'll be like hanging out with like friends from work and they'll say like I'm uncomfortable with that. I'll be like, oh wait, we have to talk about this. Like, it's like becomes like a programmed conditioned response where like as the person at that higher level of authority or whatever, you're like you hear somebody say something and you're like, oh, I really should think about this. Like, they're maybe that is that we are going to beat traffic if we go that other way. And
Yeah.
I think it's really interesting because, like, I know a lot of people rebelled when these were brought into medicine, but it's kind of interesting having, like, grown up with these as standard. Like, I can't imagine medicine without these tools.
That's a really interesting point. And when I hear that, especially that rebellion part, I'm reminded of again getting it back to that idea of the hierarchy. And I think probably a lot of physicians that I've worked with kind of feel most comfortable in that in the role of the decision maker. And when you are when that is the role that you identify with, and if you sprinkle in maybe some imposter syndrome, or you're not really comfortable in your own skin but you're comfortable in this role, then all of a sudden when someone you perceive as a subordinate is quote unquote cussing at you, it becomes very uncomfortable. And then there's sort of this like, then you sort of defer to your own authority. Well, I'm the doctor, so like, it's my way or the highway. I know what I'm doing. When in reality, this bedside nurse often has a lot of experience, and perhaps even more than you, oddly enough, as it relates specifically to this scenario. Maybe, you've mastered the pathophysiology and the pharmacology and all of that, but perhaps this specific scenario is one that's played out multiple times for this bedside nurse. And I think that approach to communicating hopefully empowers nurses to help the system provide better care for patients. But I think sometimes that comes at the cost of egos. And that's what we have to kind of tease through. I don't know, Genae, any thoughts on that?
Yeah, this was actually something that I didn't realize maybe was as prevalent within some of the physician world as it might be. I didn't even know what the term pimping was before I started medical school because I just didn't know what that was. But, to put the shoe on the other foot, if I were to, put on, a devil's advocate hat for a minute, I feel like when you are carrying the weight of decision making and you carry the consequence of the weight of decision making, which sometimes those consequences truly are life or death. And that's not something easy for us to have to reconcile and grapple with, right? So when you're training in order to carry this weight of decision making, then you also are dealing with, for a decade of this education, not being right, not being good enough, being told you need to think about this, being told you need to think about this differently. And so it possibly could be a decade worth of you're wrong at the table subconsciously in some of these exchanges as well. So I think that imposter syndrome is kind of this vogue term that sometimes gets thrown out there a lot. But I think, referencing an insecurity that you've had to like face over and over, both from a stance of, our own training, as well as from a stance of reconciling some, errors, mistakes, or even things that aren't mistakes, but just didn't go the way you wanted them to go. And outcomes were poor. And so those are real things to have to reconcile that come into decision making when you carry that end burden. So, putting the shoe back onto the nurse's foot, where they recognize something is going awry. And, especially if it's operational or something that, is maybe a trend over time, they're operating from a stance of this doesn't feel right and something needs to be addressed about it. But it's a different style of maybe insecurity than that a nurse may be carrying related to education or training or not having some of the decision rights than maybe the insecurity that the physician is carrying.
I think that's a good psychological insight. I think we could probably have a whole episode talking about quote unquote pimping and trying to define what that term means, and are there good aspects, are there bad aspects? But I mean, I think you're right that when you have a training sort of pipeline that sort of trains physicians to be wrong a lot as a method of learning, that maybe that predisposes people to be uncomfortable with somebody that they perceive as telling them they're wrong, even though, as you said before, like, the patient's at the center of all of this. The goal is safety, right? It's not a criticism of them. It's just saying, but what about this other thing that's important? But it's
Right.
true. Sometimes I think that does get lost in there. One random aviation thought before we go on, I promise I'll stop talking about this, is, it occurs to me that whenever there's a plane crash, there's always a cockpit voice recording. And there's always this sort of detailed second by second analysis of not just who said what, but exactly how it was said, and was it acknowledged? Was it closed loop? And it seems to me that that's something that we could learn from in medicine here, which is, that, like, dissecting the way we communicate with each other, like actually looking at, like, how was this said and was it acknowledged? Was really enough?
Yeah,
I think we could probably do better in that regard.
sure. And I think, this kind of pulls back to that double-edged sword of when you are being judged, right? And when you're being judged in a stance of productivity and, good moving forward versus, crossing over into tearing down territory. So I agree that, man, that's kind of what we do as part of like debriefs, right? We try to debrief scenarios, figure out what happened. But at the same time, that also relies on people sharing their perspective, which someone may or may not feel comfortable doing. They may or may not say, hey, when you were saying this, I was thinking this. So I think there is something to be said about debriefing more in a dissection manner, but recognizing that that easily could cross over into antagonism. So I think that, whoever's leading that debrief would need to be very aware of that.
Yeah, I think it's really important in a debrief to, like, make it a safe space so people can reflect, thoughtfully. I mean, it's very easy to just sort of be like, oh, this thing happened. Well, what went wrong? And maybe a better way is, start off with what went right, and maybe acknowledge your own, like, I wish I had done this instead of this, acknowledge your own fallibility to sort of set the tone
Sure.
for it. Because I think a lot of these debriefs, if you don't do them, the lessons go unlearned essentially. And all too often, right, we're busy and, like, we just don't take the time.
Hmm.
I think that's a great point, Nick. And I think as educators, we often do this when we're working with trainees and they uncover knowledge deficits of our own. At least what I think we should do is probably embrace that vulnerability, embrace that deficit, and be like, you know what? You're right. Like, that's an interesting point, and I don't know. Let's try to learn that together. Let's try to get better together. I think there's an evolution that goes from, man, I'm really insecure, I hate the fact that you made me feel uncomfortable, to that end state of, like, embracing, quote, not the failure, but embracing the lack of knowledge or embracing the opportunity for growth. And I do wish that we were better about implementing that paradigm to our communication skills, especially in these high pressure situations. I don't necessarily make that a big part of my debriefs now, but I think I need to.
If I ever make a mistake, I'll be sure to acknowledge it at the debrief, is what you're saying.
Yeah, correct. Thank you. Yes, it's yet to happen. But every once in a while, correct.
I also feel like it's easier to acknowledge a mistake or acknowledge a learning point when you're maybe in the training environment. And so sometimes when you're holding more of an authority role, that's when it's harder to even say, I don't know.
Yeah.
Yeah, that's true. Though I will say that I probably end 55 or 60% of my communications with pharmacy with "thank you for teaching me that." So, like, it's something I try to force my, it's like, it's good to ask people why they're suggesting something, because that often does lead to the, like, oh, wow, I didn't know that. That's a great fact. Thank you.
Mm.
So just to sort of follow up on what we were saying before, so given your kind of unique perspective as a ICU nurse, as a medical student, how has your perspective on communication in the ICU evolved over the years?
I would definitely say that when I first started out, I felt so much insecurity, right? I was a new grad nurse. I was in an ICU, and it was a surgical cardiac ICU at that. So, man, that was hard to feel like I had a
The
big
scariest doctors,
scariest
CT
doctors,
surgeons.
scariest surgeons. Um, but I really learned, I was trying really hard to learn both how to navigate the responsibilities as well as how to figure out who to call, when to call, what, how to gauge magnitude, how to gauge, what really is priority and an emergency and what is a notification. So when I first, I guess, started in trying to learn what to communicate, it was really surrounding the logistics. Throughout some different roles that I've been able to take on, I found a different style of communication might be warranted in different situations. And I kind of learned to evolve my communication style to a situation. Within, the flight environment, I probably use SBAR the most. And that was because I feel like that is most like straight to the point. It's the most time efficient. You're able to communicate within a short duration, either a large problem or a very narrow problem, and be able to say, here's what's going on, here's what I need from you because of it. And within our role, we do have obviously our protocols and autonomous decision making within that. But the opportunity to have a patient that falls outside of protocols is frequent. And that might be a phone call to our medical director or a telecritical care that can help support decision-making that may fall outside of protocols. Sometimes that's related to the complexity of a patient, and sometimes that's just notification. Hey, I know what to do, but this patient falls outside of protocol. I'm just letting you know. That is often a not unheard of type of dialogue. So whether it's to brainstorm or even just notify, I like SBAR probably at this point.
Yeah, and I think just for our listeners who may not be familiar with SBAR, so it's not a really bad sandwich place. SBAR is don't sue us, SBAR, or whatever that place is called.
Are you talking about Sbarro, the pizza place?
Yeah, exactly.
Dude, what planet do you live on? Oh my
I live
goodness.
on a planet with better pizza than that.
That's like the place in the office. That's where Michael Scott wanted to go to in New York.
Exactly. That's his New York City pizza go-to place. So SBAR, situation, background, assessment, and then recommendation or request. And yeah, I think it's a great schema. It can be just like a sentence or two. You can convey a lot of information, Mr. So-and-so is febrile. His white count is also up. I'm concerned he might have a fever. Do you think we should start antibiotics? Very quick, right? I mean, or it can be like, my wife's like, hey, you're working tonight, but so you're not going to be cooking dinner. Maybe we should order something. What would you like? It's just like it's one of these like structured communication tools, which I think is incredibly effective, not just as a way to communicate with others, but also to sort of think about problems. Like what's the quick summary? What's the background? How do I assess it? Put pieces together, and then what do I want to do next?
Yeah, and I think that's a great hybrid approach too. Because if I think back to like again Outliers and Genae, I don't know, Nick, if you've read about it, Genae, and you might remember this.
Yeah.
Like in the so back to that chapter again when they're talking about cockpit communications, you had essentially because of cultural factors, major issues were like subtly hinted at rather than mentioned overtly. And so that's kind of what led to a lot of things being missed. And so, but on the flip side, like as humans, we don't always want to be, aggressively communicating every single factoid or like in your face with every single, element of the day or what have you. And so I like the SBAR approach. Specifically, Nick, I like the Jedi mind tricks that your wife plays on you. Specific, like that idea of like, oh, hey, this is an issue. I think we should do something about it. What do you think about doing this? And so it pretty clearly indicates what your wish is as the SBAR deliverer without like shoving it down the recipient's throat. So I think it works well.
Yeah, I feel like I've definitely loved it because it also helps me articulate exactly what I need. And within a transport environment, I really actually like SBAR a lot when I'm communicating remotely with someone. So A couple of recent ones I've had have been something as simple as, okay, this pH has fallen outside of our protocol for our own autonomous vent management. All right, get on the phone. Hey, doc, pH is this. It's outside of my protocol. Here's what I think should happen. Here's the background of what's happening with the patient. What do you think? And so that can be a very streamlined conversation that can really take 40 seconds, truly, at the most. And when you're also doing this, you got your phone to your ear and your shoulder, and you've also got your hands doing 3 other things at the same time, trying to load the patient into the helicopter. That's a really effective way to communicate. But you can also expand it to another type of circumstance. I had another one, sometime in the last year or so, where it was a cath lab patient, so cardiac etiology. They were unable to stent it and needed to go to a facility with CT surgery. And so unstented MI cath lab patient, you would think it would be pulmonary edema ARDS style of lung physiology. But as soon as we hooked the patient up to the ventilator, some of the waveforms and indicators on our ventilator told us we've got something else going on underlying. And of course, we asked to pull up the chest x-ray, and I don't know if you ever have trouble opening up images, but of course couldn't open at the moment you wanted to.
Right.
So I got on the phone with our telecritical care doc and said, I'm concerned there's some other mixed pathology happening with our lung physiology. Can you look at a chest x-ray right now? So I think there's certainly the capacity to have more of an expanded conversation with SBAR or a streamlined conversation, whichever may fit the circumstance.
Right. And I think that's a really good point, which is that, sometimes I encourage people I work with to put an R on the S bar, right? That sometimes when there isn't a request, when there's just, a problem, like I had this track coach who used to say bring me solutions, not problems. And it doesn't have to be the right solution, but at least have the R, have the suggestion. And it can be a very vague suggestion too. Can you look at this x-ray for me? It doesn't have to be a specific management plan. I think it's just very good to ask people for what you want. And sometimes when I'm working with somebody and they don't give me the R, I'm push them a little bit. This person's nauseous. Okay, what do you want to give them? Make people go through the exercise of what would they do if they had, complete authority to do it all completely on their own. If they didn't have me there, what would they do? And I think it's a good learning exercise at the very least.
I'll even take the R and make it a review instead of a request if I'm using SBAR to form a feedback session or a debrief. So I will take and go situation background assessment and review the aspects that have been discovered within a feedback session as a summation at times. So I'll even use it, not even problem oriented.
I really like that.
Yeah, that's clever. I'll probably end up stealing that. I'll make sure to cite my sources though.
I'm going to quickly shameless plug for episode 31, which is telecritical care. You heard a reference to how awesome telecritical care docs are, and listeners, if you haven't listened to that episode, you should go back and listen to it because you'll hear the other side of that phone call.
That's right, and I think coincidentally, those 2 telecritical care docs are friends of yours. Isn't that right, Genae?
They are, yep. They are people I have called many times, so appreciate their support.
It's funny how critical care is a small world, and it's we're one big family. So I do want to, in the spirit of critical care, bring this back to sort of an ICU environment and ask you a little bit more about strategies, and specifically strategies that maybe you have found in your career have been most effective when you're communicating not just in the ICU, but during high pressure situations with multidisciplinary teams. How have you found that dynamic to work effectively, or maybe not effectively?
Yeah. So in high pressure situations, I honestly think the communication style has to turn towards pertinent, short, what adds value and what doesn't, right? So that can come across as harsh, right? That's a harsh communication style if you can be on the receiving end of it. And I recall actually at a time when I was a manager, I had a new hire who, when the patient arrested, felt that harsh communication style was more antagonistic and as personal offense. And that was something we had to really walk through and talk through together for some time. That's what's pertinent to a critical situation. So when I am responding to, these types of scenarios, then as one of the team members, whether it be on a code blue team or rapid response, or even just showing up, within an ER, really identifying roles and clarifying what you can do and what you are not doing is so helpful. Because sometimes when a code gets called, I swear everyone comes. You have, 50 people who respond instead of just the code team sometimes. And so being able to say, your mass transfusion, your drawing labs, you're my compression line, you're my airway support is a great way to just delineate and then assign someone to get rid of anyone else that's not pertinent, right? So I think that, within a high pressure situation, it really is okay to change your communication style to be directive and or collaborative, but with purpose. If there is a need to, correct something or give, constructive feedback, that's what the debrief is for, right? You can always address the dynamics and what happened during a debrief. So I think that's some of my, I guess, best ways that I've come across some of that.
Yeah, I like that a lot. That, I mean, you can acknowledge that the terse communication of a life or death situation was terse in the debrief. One thing I also like to do too is, like, especially when it's unfamiliar people, sometimes like the communication styles get a little changed, like when you have this flood of people you don't know. And I always like to ask people their names, and I'll probably forget like 3 seconds later, but you say like, "Oh, what's your name?" "Oh, okay. Frank, do you mind running the rapid infuser for us?" Like, that way there's a little bit of softness. It takes like 2 extra seconds, but it doesn't like waste a lot of time with like introductions or something. It's like the minimum amount of closed loop. You address somebody by their name.
Absolutely. Yep, totally. And even if it's just one follow-up from that, cool, Paul, hang meds for me, that's a great way to just get it going.
So I'm curious, how do you ensure that all voices, from nurses to doctors to allied healthcare workers, are all kind of respected and heard in these conversations? Like, when there's a big power dynamic, how does that not sort of like make some people feel trepidatious about speaking up?
I think some of my favorite, I guess, collaborative moments can come from some of these. So during some of our high complexity transports, we'll bring different personnel with us to help have different roles. That might be a perfusionist, that might be a CT ICU RN, that might be a respiratory therapist, that might be a high risk OB specialist. Any of those types of extra expertise that are coming to the table are coming with some sort of value or expertise that in some aspect of what they bring. So, emergency aside, so if it's not time sensitive and you have the opportunity to just collaborate, if I feel or have taken on the synthesis role of some type of an environment like this or a transport, I will actually summarize in some of the transport phase. Let's say we've gotten to the bedside, we've taken care of, moving things over to transport style of equipment, we've loaded in, whatever it is, you found a time period, you found some sort of lull within a natural course of work. And you take that lull as an opportunity to summarize the clinical course and what the next steps from there are. And that lull helps people feel valued because we're all on the same page and they've been asked directly, okay, how does our vent synchrony look? How does our pump flows look? And they get to contribute what their expertise is within that moment or within that aspect. So I think if you can have some sort of leading, planning session as well as summarize, you're sharing what page you're on and helping kind of synthesize all the pieces together. But you're also helping give ground and give a forum for the experts to be able to share their thoughts.
I really like that. One of the things that I think we've figured out how to do pretty well at my shop is the structured handoffs for post cardiac surgery patients, where the anesthesiologist, the surgeon, the perfusionist kind of all sort of share different parts of the story in a structured way. And I think like calling on people is kind of a nice way to take some of the pressure off. Like, it's not as daunting to speak up if somebody's going to ask you about, and what about the ventilator? And what about the pump? And what about, et cetera?
Yeah.
That's a great framework, Janae. I think that'll definitely be helpful, I think, for me and for our listeners. I also wanted to ask you, based on kind of based on all of that, is there an experience that you can think back to where some of the strategies you've discussed and some of the approaches you've mentioned, have actually panned out in a way that you could share with the audience, kind of make the rubber meet the road, so to speak? Give us an example of a case where communication really was effective, something that we can kind of take home and reflect on ourselves.
Yeah, it's sometimes hard to think of like great examples over time when you feel like sometimes you actually let them go, you kind of do the best you can in a scenario and you let them go. But
Right.
I do feel like there are a lot of experiences, and this may be one of the fulfilling sides of medicine. I do feel like we have experiences that really do maybe shape or change even like our brain chemistry to just think about things, or maybe we're moving or touching. This is neither of those, but it was a great experience. So this was probably this was a transport. So it was within the rotor nurse environment and the rotor role. And it was a transport of a patient within a community hospital, a smaller community hospital, and needed to go to a higher level of care. And the patient had an underlying metastatic disease, had just had a stent placed for some improved renal perfusion, and was in a profound lactic acidosis, and presented to this community ER with bilateral PEs. And so this patient had a lot of physiology going against them. And when we got dispatched, because we are dispatched with pretty minimal information, we don't really know much besides like logistics of flight that might be height or weight or some aspects of that. We have to kind of get used to walking into unknown and not knowing what we're coming into. So as we walked into this community ER, there was one physician. I don't know if he was even staffing the whole hospital. It was just at least he was only one in the ER. And as we walked down the hall, he came out of the room, and I was positioned at the door so I could see into the room and lay eyes on the patient and the monitor. And as he walked into the room, or walked out of the room to meet us, he looked at myself and my partner. It was a paramedic partner that I was working with. And he said, "I've called you and another company, and whoever can take this patient first, I'm going to send with, because I think she's going to arrest." And, when you're met with that, you kind of go, what's going on? So I look in the room as he's saying this, and the monitor
Sir, this is a Wendy's. Like, calm down.
shows her heart rate was 180. Her blood pressure was something like, at the most high 70s, over 40s. The RT was trying to put a BiPAP mask on her, and she was like GCS 9, maybe 10, just kind of pulling at the face mask, very confused, mumbling, not coherent. And so, I look in the room and I look at him, and you could tell in that moment that one, that airway's not secure and she's going to code, right? So I looked at him and said, "I have concern over her airway." And he said, "Yeah, but she's going to arrest if I tube her. So she needs to get out of here now." And it was in that moment that I realized he was in a stress response, right? He was in this catecholamine dump. And so I looked at him and I said,
His heart rate was 180 also.
his heart rate might have been 180 also. And I said, "I'm afraid she's going to arrest too, but we're here and we'll help. So let's go in there." So I think even just acknowledging that, hey, you're not alone anymore. And he wasn't ever alone, but at the same time, having just more hands in a place where he doesn't have a lot of hands to begin with just helps bring resources, thoughts, even a transport option, right? So you come, committing to partner, committing to support someone. So we walked in the room together, and we evaluated a good strategy for hemodynamics and intubation, with a very real risk of arrest on our hands. And ultimately, he went to go talk to the patient's family to describe what needed to happen, as well as the very real risk of arrest and not being able to get her back. while we prepped some meds, got some drips hanging, we started to strategize how we were going to prepare for a very critical situation. And somehow we were able to prevent an impending arrest within that, just by having good collaborative commitment to partnering together with the nurses, the physician, and our transport team within that ER.
That's a great story. It's a story like I've kind of been at various points in my career, and I'm sure Nick has too, been part of similar stories where like you can either bring a calming presence or perhaps you need a calming presence to help you think straight. And that story also dovetails really nicely with something that I did want to ask you about, Genae, and that's really the balance as it relates to communication, and how oftentimes as bedside clinicians we get the blinders on, we're focused on the problem. And so in this case, you told the story of the ER physician who was focused on how am I going to fix this problem? What am I going to do? What am I going to do? But then you also alluded to this family, right? And so there's this family that's watching, and they're sort of like they're the collateral damage of everything that's going on. And so a lot of times, at least in my experience, I have to, as let's say I'm the senior most clinician at night, and I'm the only person, like I have to deal with the problem in front of me. I kind of have to an extent, put the blinders on and take care of business.
Yeah.
And so I lean on my nurses to help coach the family through what's happening and comfort them. And so how can I either in that moment, or maybe it's not even in that moment, maybe it's before and after when tensions are not so high, how can I as a quote unquote team leader help empower my nurses to fulfill that role as well, of being like the compassionate communicator to the family and to loved ones?
I think that's actually a very seamless transition or request to make of your bedside staff, your bedside nurses. They have been probably at that bedside with genuine intent and care of caring for this loved one for, maybe days on end, depending on the circumstance, right? So they've probably developed a rapport and relationship with the family already. So I think that's a very natural and seamless opportunity to involve them and help them interpret, help them be a part of even answering questions or saying, what questions do you have? And I'm happy to take them to the physician for you or something, right? So I think, of course, time sensitivity aside, having them in your corner, both for learning and helping them have the opportunity to teach family, as well as being able to play a supportive role for family, is one I always really loved, actually.
I love that you focused on how it's kind of a seamless transition for the bedside staff, because I think it does, at the end of the day, to me, that your perspective on it reminds me, and hopefully reminds our listeners, that in medicine we're in the business of healing and comforting, and that is not necessarily just fixing the pH or improving the blood pressure. It's kind of holistically approaching both the patient and their family, their loved ones, etc., and trying to bring calm to the situation, trying to approach a problem, which, I often talk to trainees and I say this, like, when we meet a patient, it's very likely the worst day of their life or close to it. And I think if we can remember that in the way that we conduct business, it can go leaps and bounds in terms of establishing relationships with our patients and bringing them, maybe not a cure, but at least letting them heal in whatever way that is going to manifest in that particular situation. At least that's my approach, Nick. I don't know if you wanted to comment on that before we continue.
Yeah, no, I think that's a great perspective to have, which is that, however rough a shift you're having, however rough a day you're having, like it's definitely not nearly as bad as your patients or their families. And so it was like walking in there with that like humility. Really important. Getting back to this topic of multidisciplinary communications, and specifically multidisciplinary rounds. I'm curious your thoughts on kind of how that handles, because sometimes we have very different frameworks for communicating with people in different roles, and I'm curious if you think that's like a good thing, a bad thing. Sometimes like there's a tendency to pimp medical students, but then not ask any questions like that of nurses.
I will say this might be an unpopular opinion. I don't hate pimping. I don't think it's that bad. I
You are
think
in safe company. I think it's great.
Oh
I
yeah.
think it depends on
Mhm.
your relationship with your mentor, of course, and is the intent to learn or is the intent to embarrass, right? And so
Yes. 100%. 100%.
yeah, and so I feel like if that role has translated to me in nursing, I can think of so many times when, the intensivist I was working with that day would say, "Have you looked at the chest x-ray? What does it look like?" And being able to help guide a mentoring style of, I guess, quizzing or, um, you know, probing for you to think more about a circumstance or a situation is actually something I think we kind of love, so long as it's done with the right intent behind it.
Yeah, I think that's a really good point. I think, it's never really made sense to me why we don't do that more. And something I try to do on rounds. There's always sort of an element of like if it's somebody's first shift in the ICU and they're like you can kind of hear in their voice that they're like nervous presenting. Maybe don't ask them, a Starling curve question, but like yeah, I think we're working in the ICU in this place with all this physiology often because we love it and we love talking about it. And so that goes for everybody.
So, Nick, Genae, it's funny that you kind of express that because I remember at the inception of this podcast, Nick was recording from his lovely home in Washington. I was recording out of a shipping container. And when I was actually going to work and working in the hospital, I found that the nurses there were super hungry to learn. And there were times we had a little bit of extra time on our hands, maybe more so than when we're stateside. But I would start to push the nurses more than I really ever had when I was back in my typical training environment. And in fact, I would pull out like my board review questions when we didn't have patients and start to go through those. And I found that, like, oddly enough, a lot of your nursing staff, much like yourself, have aspirations beyond nursing and they want to learn. They're hungry for knowledge. Maybe they want to just be the best bedside nurse they can be, which is amazing and phenomenal and incredibly important, or they want to become physicians or CRNAs or whatever it is. And so it's interesting how you might be reluctant, as Nick was alluding to engage the bedside staff in the way that you might engage a trainee. But I found that some of my most, I don't know, fulfilling educational experiences were with the bedside staff. I don't know if that's something that you experienced before you started going into med school, before you started med school, Janae.
I would totally echo that. I think inherently within a high stress environment, it's got to be coupled with some sort of fulfillment, right? And that I think you're curious. You're curious to know. You may start out with kind of a baseline proficiency. How do I make sure my patients are safe, et cetera, right? But at the same time, that development of learning how to become proficient inherently has greater learning of physiology, greater learning of how to know what to do when critical search situations arise. I think some of my favorite learning and teaching moments have been from side by side with the intensivist working in the room with either knowing or not knowing dialogue, or even maybe this was my own experience, but no one I worked with ever made me feel stupid for not knowing something. I would just say, "Well, what do you think about, maybe the CVP in a circumstance like this?" And instead of responding with, "That's dumb. Why would you think of that?" They would actually counter with, "What else might make that not necessarily part of the picture? What would be contributing to a false, elevation of that pressure or something," right? So you have some sort of dialogue that is supportive, and countering something with, if what else could be going on, it's probing you for further I guess, intellectual exploration instead of just closing down a conversation. And oftentimes, especially in the ICU, you are working together for longer than just, the 7 minutes to round or present on a patient. You're usually often close by in proximity for quite some time.
That's absolutely true. And so I think as we explore these relationships with our bedside staff, conversation begets conversation, learning experience begets learning experience. And so I think shying away from that is probably the wrong answer, but rather, kind of as you were saying, like the goal is not to embarrass, the goal is to educate and to grow. And so as long as you approach it that way, I think it's pretty effective. And the return on investment there is just like astronomical.
Absolutely. I feel like that really helps establish we're all on the same team. And the nurse gets to know a little bit more of how the physician thinks and what's important to them. And so when you do get the 2 or 3 a.m. phone call, it's with a little bit of credibility behind it that, hey, I've
Mhm.
explored this with you before. Here's what I know, you know?
Here's what I know, and here's what I think we should do, getting back to your earlier point, is like you've
Right.
empowered your staff with like the ability to make suggestions, which in turn, one of the principles of like effective communication is this idea of, you know, Nick alluded to it with his kind of track story. He's like, come with a solution, because that takes out that element of like that cognitive hiccup, and it's like, oh yeah, he or she's prompting me,
Mhm.
and yeah, that is like exactly what we should do in this situation. But it may take you longer at 3 in the morning when you're woken up in the middle of a dead sleep to come to that conclusion. And it's because you laid that foundation with your staff days, weeks, and months ago that you've got that well-oiled machine. And I think that's really important. I did want to ask you, sometimes that machine isn't so well oiled, and sometimes you do have friction points. And I
Well,
wanted
that
to
was a great transition, by the
I
way.
thank
That
you, thank you,
was that
thank
was
you.
like, oh man, is there like an award we can win for that? That was so well done, man.
I've I'm working to that. I'm working towards that daytime Emmy for
Yeah,
podcasts. Yeah. so so um so when a communication is not effective, and you could potentially have turbulence that arises amongst the team, there's sort of, I guess, two approaches. There's like just not acknowledging it and moving on, or and you kind of talked about this, Janae, with that code situation you brought up. It's like, you know, someone felt that the communication was antagonistic, and you dealt with it, and you worked through that. So maybe you could unpack some of that in terms of strategies that we can use when friction points do arise and we need to sort of smooth them over.
So I would say that by far and large, your greatest source of friction is going to come from miscommunication. And so I think that in and of itself, understanding where miscommunications come from is something to address like on the forefront. It's a preventative strategy. You got to figure out how to prevent or quickly correct miscommunications because playing damage control is always so much harder than just addressing something in the moment. So I can't tell you how many times I have done the wrong thing. I have made both big and small mistakes, put my foot in my mouth, whatever it may be. And I think it's easy to shy away from that. I think it's easy to, try to, move on from it without addressing it. And if I just pull back and say, hey, I feel like I shut that down and I am sorry. Let's address that right now. I think leaning into something that's really difficult psychologically to do is something that I think is only good for the situation and just for me in the practice doing it. I think, from just a less abstract standpoint, big miscommunications come from, you know, progress notes that get written that say something different than what maybe an in-person interaction may have included. I think miscommunications happen when an understanding of a hospital policy is different than what, may be happening with a circumstance. Or maybe something is different than what has traditionally been done or that they've had exposure to for the last couple of years. Even, something that's less usual, but something that feels uncomfortable, but is right in a circumstance, a little bit of explanation to clarify that or make sure things are accurately reflecting what the intent is probably a good way to avoid a good chunk of your miscommunications. And some of that may be, hey, I don't know what hospital policy on this. Maybe what is hospital policy on maybe staffing 1-to-1? What is hospital policy on, patients who come in with SI or overdose, right? That may be just some of the way to clarify and clear up what could be turned into a very quick miscommunication in the future, right? I think that another area that we see communication shut down is when we are dismissive to the comments or to the idea. I think I always like to assume good intent, and I really do believe human nature is to reassure. And so sometimes when someone brings a concern, we want to reassure it. We want to maybe think through why something may not need to be a concern. But I think hearing, a concern that's brought forward is valuable to unpack instead of try and just reassure, because the end result is coming off dismissive. The end result is coming off as condescending, or that was not a valuable input, even if that's not maybe what we intended to communicate. I think, another friction point can really come from not knowing what the next steps are and not closing the loop on what a circumstance might be. So if, myself as a bedside nurse am calling because the hemoglobin has now dropped to 6 and the response is, okay, cool. Then you hang up and you may be expecting the physician to come to the bedside, or you might be expecting orders to be put in, but you might be expecting something that maybe the clinician on the other side is not planning on addressing right away. Maybe there's some, aspects that are unknown. Maybe we're keeping a lower threshold for transfusion. Maybe they have a history that's not known there, or maybe they want to loop someone else in and get, hey, I'm going to call the surgeon perhaps, or I'm going to call a friend and discuss something. But, on the receiving end, there's no follow-up, right? So that's just that closing the loop on whatever the communication style is. Okay, cool. Thank you for letting me know. I will either call you back with orders or I need to call the surgeon, right? Being able to close loop on whatever that next step is going to be.
Yeah, I think people sometimes feel uncomfortable if they don't know what the next step is, but like even just saying, okay, let me get back to you. I want to talk this through with somebody else. Like, it shouldn't be embarrassing to say that in response, to an unexpected critical value, for example.
Yeah. And I think if, to empower someone on the receiving end of a lack of a closed loop to be able to say in return, what should I expect next? Do you need orders? Do you need time? What do you want from me next? Is actually a good way to even guide the conversation and pull someone that you're communicating with into a frame of what the next steps are.
Right. Yeah, we've mentioned the like Jedi mind trick before, which I think is a very powerful, critical care nurse skill, especially sometimes with residents. Like, oh, do you want me to call the surgeons about the falling hemoglobin?
How do you know about
that? It's been used on me enough times. The Jedi mind trick doesn't work anymore. I'm like Jabba.
Oh God. Oh my goodness, that's hilarious. So Nick, do you we spent a while now talking about some granular elements of communication. I'm wondering, Nick, if maybe you want to take this thing home with a case.
Yeah, I think that's a great idea. So we always like to do cases. So let's kind of put some of these tools to the test. So let's say that you are the night float intern and you get called about a patient who's short of breath. You can tell just from kind of the appearance that the bedside nurse is stressed out by the situation, both by this and maybe workload in general. It's been a very busy night in the ICU. They call and they say, "This patient looks short of breath. Please come take a look."
Well,
pause.
Honestly, my first initial thought is, what patient are you talking about? Because that might actually be very real on the table. I might have no clue what patient is being referenced, right?
Yeah, that's a great framing question, actually.
Yeah.
That like if you're an ICU nurse and you have 1 or 2 patients, but you're like the doc covering at night and you have like 30 patients, like it takes a little while, like shuffle the pages, like who are you talking about? Wait, what is this? Yeah.
And is this
especially
someone
like
for, or is this someone that I know well? I don't know yet.
And especially when it's like a room number and they're like,
yeah,
313. Like what? Like that's not. I don't know what that is.
Where's 313? No. Yeah. So I think that is probably a super common and real, maybe even type of response, because when you're on the other side and in that stress, you might be calling, in more of a frantic or emergent style of frame of mind, right? So I guess to follow suit with what I genuinely would do is I would try to address the frantic nature first. I'd probably say, okay, tell me which patient you're talking about and what do you need? How can I help? Right. And with that, if the conversations still seem to be more abstract or not concrete. I might actually lead questions, right? Okay, what are their saturations? What is their rate? What support are they on already? Have they been on any additional support before? Is this a change? Have they improved or gotten worse over the last couple of days? I might actually lead some of the dialogue to drill down what actually is happening if this patient's work of breathing is pretty compromised. And then you got to gauge what type of response you get. If the response I get is one that is receptive to the questions, then maybe I can help, guide, okay, I'm wondering about this because of this, or, okay, that's good to know. I'll check the chart and get back to you. Oh, they just had surgery. Okay, let me see what's going on, right? You just bring more information. I think, the real response could be that they just want to get off the phone. They don't actually want to sit on the phone and talk to you anymore. And in that case, I might directly ask, do you have an emergency going on? Because that is a good way to just say, do I need to run over there right now? Or can I look at the chart and figure out what's going on? Or are you really more stressed about another patient you actually haven't even told me about? And that's actually one we might need to prioritize first. Do you have an emergency happening right now that you need help with? That might be a good way to just get to the chase.
I like that question a lot. I think that's great. I mean, I think another good sort of observation here is that, in general, when somebody says, please come take a look, it's very rare that you should not please come take a look, but it's a question of, am I walking or running? Am I reading first? What am I going to, like, when am I going to come take a look, and how am I getting there?
Totally.
So I guess, let's say that you ask your clarifying questions, and you're getting a little bit of information, but the report's kind of lacking. And then, you chat a little longer and things are getting more and more terse, and you're getting a little bit of attitude. And, I'll say, having been maybe on both sides of these types of exchanges, and I'm not, not to imply that you never get short with a colleague, but I'm sure like we've all been, susceptible to stressors in life and maybe communicated things less than effectively. So if you're trying to get information and you're continuing to receive, kind of not get what you need, what specific strategies might you use in that situation?
I think that is probably best served face to face. So it sounds like that's someone I need to go talk to individually. Like you said, seeing the patient, is something that's going to happen, and in what time frame. If I'm truly getting very little, I might prioritize just going over there immediately, laying eyes on the patient, figuring out if an emergency is occurring, and then being able to talk to whomever it was that called, validate and thank them for calling, and validate that, okay, here is what shortness of breath looks like, and you picked up on this, and, thank you for calling. But then being able to say, I was sensing this, I saw this, what was your thoughts during this interaction when you said this? Gives them the opportunity to kind of share, maybe with in-person opportunity to dialogue and collaborate a little bit better.
Yeah, I like that. And I think sometimes people act very differently on the phone than they do in person. And sometimes you can have more of a conversation, face to face, or sometimes you can even just like lower your voice a little bit, like, so nobody around is hearing, and say like, is everything okay? Like, you seem very upset about this. Like, is there something else going on here too? Yeah. I joke sometimes that, like, I hate it when you have a meeting that could have been an email, but like, these are, messages in the hospital are usually emails that should have been a meeting, right? Like, it's clinical messages are often like that, like, there's so much more information readily available to you if you're there at the bedside.
Mhm.
And there's so much more information about the person who's trying to communicate with you,
Yeah.
like what is going on with this person who's calling you is also an important consideration.
Sure. And even just validating the credibility of, they may not be able to give you the information that you might have the training or brain power to think, I would want to know this, but they've obviously picked up on something. And that something either needs more education or that something needs addressing, right?
Right. And sometimes that something is a perfectly it's like a very good insight that somebody looks really bad, but there just isn't a good way to explain why they look so bad. Like somebody who's like picking at the bed sheets all of a sudden. Like there's just like certain behaviors that like when you see them before, sometimes you're like, this just doesn't look right. And if you don't know how to put that into words, like sometimes like all you can kind of say is like, this doesn't look right.
Right.
And I think, Genae, you mentioned this very early in our talk, and I want to underline it, I think, but one of, I think, the most effective communication strategies is to remember that we're sort of all on the same team. And people are, if you assume that people have the best intentions, then I think that helps you reframe ineffective communication into, okay, maybe this is a stressful situation and this individual doesn't know or isn't equipped to deal with the stress. It's not that they're calling me with a crappy handoff because they don't like me because it's 2 a.m. and I'm an intern and they're just trying to give me a hard time. No, it may very well be because this person has the best intentions. They want to help this patient, but for a number of factors that maybe you don't have visibility on, they're just not doing it very effectively. And so that's the situation where maybe you should just go to the bedside, as you kind of, I think, astutely pointed out to, and just attack the problem head on, and then kind of sort through some of the communication lapses when it's appropriate to do so.
Yeah, hands down. I think that's actually one of the best ways to build credibility within your team, because then you've got a partner who said, when I called you last time, we talked about this or whatever. You've built some sort of rapport. You've built some sort of relationship that has been productive to your team by being able to just address something, validate it, and just be able to engage with that person one-on-one.
And with that, we've come to the part of our show where we'd like to say thanks. First of all, thank you so much for our guest for joining us. You imparted a lot of wonderful, wonderful experience and wisdom. Any final thoughts you want to share?
I just want to say thank you to you guys for this podcast, for wanting to expand the thoughts and critical care amongst all of the team. It's been a good expansion this season.
Well, thank you.
Thank you, Genae, and thank you for your time and for participating. Hopefully this is, the first of many collaborations. Would love to work with you, I think, again in the future if you'll have us. It's always nice to talk to someone who's enthusiastic and brings a breadth and a depth of knowledge that is different than what we sort of bring to the table. So thank you for sharing some of that with us and with our audience. To our audience, of course, we are hopeful that you guys learned as much as we did from this episode, and you'll take some of these lessons back to the bedside and to your clinical practice. If you want to learn more, you should check out our website, read our show notes, www.criticalcaretime.com. While you're there, please subscribe to our mailing list, grab some merchandise from our store, leave a comment, all of the above.
Yes, we'd like to say a special thanks to the people who left us reviews, comments, and particularly 5-star reviews. Those really warm our hearts. If you want to reach out to us on social media, we love getting comments. We try to reply to all of them. You can inspire us to do new episodes. You can tweet or X at the show at Crit Care Time, or individually at Nick M. Mark or at Askins_Razor. We're also on Threads, Instagram, and YouTube.
We'd also like to take this opportunity to say thanks to our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes of Season 2 of Critical Care Time have been sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And before we go, we'd like to say a big thanks to the incredible members of our team who make this show possible. Our editors over at Podpaste, and Kurt Belknap for the awesome theme music you're hearing right now.
Thanks, Kurt. And finally, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I am, and always will be, Dr. Cyrus Saskin.
And I'm Nick Mark. See you next time.